Okay. Hello, everyone, and welcome to today's session on COVID-19 breakthrough cases, vaccine efficacy, and treatment. This is the third session of our Guam clinical updates presented by Cedars-Sinai Medical Center in collaboration with Guam Medical Association. This session is CME accredited. You can find the information now on the screen or in the chat box. We will also email the information to you afterwards. Please claim your credit within 14 days. A recorded version of this webinar will be available on demand. Last housekeeping item before we move on. Please feel free to leave your comments and questions in the chat box during the presentation. We will address all of them in the Q&A session later. Now let's move on. I would like to introduce today's presenter, Dr. Jonathan Grein. Dr. Grein is an infectious disease physician and Director of Hospital Epidemiology at Cedars-Sinai Medical Center. He is an Associate Clinical Professor at UCLA and co-chair of the Infection Prevention and Control Committee. He oversees the Special Pathogens Program, establishing Cedars-Sinai as one of the 10 national Ebola and special pathogen treatment centers. Dr. Grein received his medical degree from UCLA. He completed his medical residency at Cedars-Sinai Medical Center and his infectious disease fellowship at the UCLA affiliated program in infectious diseases. Thank you for joining us, Dr. Grein. The floor is yours.
Hi, thank you very much. I really appreciate the invitation to be here to speak on this topic. Let me share my screen. And if someone could just confirm that they can see and hear it okay.
Yes.
All right, thank you. So this is the title of the talk. Let me scoot ahead to our outline. So what I'm hoping to do over the course of the next 40 minutes or so, first is to just give a brief background, a look at the current epidemiology and of COVID-19 and talk a little bit about variants of concern, specifically the Delta variant. The second part, I'd really like to focus on some of the highlights with regards to vaccine safety, effectiveness, and then I know there's been some interest in really kind of trying to understand what we know around breakthrough infections. So I will admit it's been a challenging time to try to put a talk like this together for these topics, because I will say there's a flood of information kind of coming out, which is great. So what I've really tried to do here is highlight some of the key, more recent articles that have come out that we can go through together and discuss. And then lastly, just for the last few minutes, I'll provide kind of a brief overview about some of the data supporting some of the treatment recommendations. So we can end with that. My disclosures are listed down there. And excuse me, of course, happy to take any questions towards the end as we go. So first, let's start with a look at the current issues with COVID-19. This is just a view of the global perspective of cases. You can see as of today, according to the WHO, over 232 million confirmed cases globally. This is for sure an underestimate when you consider perhaps limitations in testing resources in some parts of the world. And sadly, over 4.7 million deaths to date. You can see there have been several waves now of COVID activity over the last year and a half. You can see that the Americas and Europe in particular have comprised the majority of cases, although there's the potential for some testing bias in this data, of course. But clearly, this is a pandemic that's had tremendous global repercussions. This is a look at the COVID experience in the United States. I opted to show these graphs as per capita rates to make a couple points. You can see the kind of various waves that we've seen in the US here. When you look at the cases data on the top, the initial wave of COVID-19 in the US was really predominantly impacting our older patient population, as represented by the more purpley colored bars there. The second wave, which we experienced in the winter of 2020 and early 2021, was predominantly really much more of a middle-aged effect on the middle-aged population, really comprising the highest rates of infection. And now more recently, this most recent wave that have gone through, much younger patient population, really a shift in the demographics through these major waves we've seen in the US. And then when we look at the impact, however, on mortality, as shown on the bottom, you could see that really across the board, our older age patients have always comprised the highest rate per capita of mortality. However, I will point out the impact of the vaccine, particularly during the last wave, where fortunately many of our older people in the population have become vaccinated, recognizing they're at higher risk. And you can see that the magnitude of the mortality increase was much more muted than it had been in previous waves. So I think in some ways this provides some optimism, although for sure these numbers are quite staggering. Like to just give a brief overview of the virus itself. Forgive me for getting back to the basics. The coronavirus family of viruses are enveloped RNA viruses. There are a couple different categories of these. There are some coronaviruses that are ubiquitous in the human population that are typically the cause of the common cold. And then there are the more epidemic members of the coronavirus family, of which the initial SARS virus back from a couple decades ago is a member, as well as MERS, and now, of course, SARS-CoV-2. We do know coronaviruses in general are a frequent cause of respiratory as well as GI illness amongst not just humans, but also animals. And the illness it can cause in humans as well as in animals can range quite widely from anywhere from very mild disease to very severe disease, and of course, life-threatening illness. The virus itself, and specifically talking about SARS-CoV-2, is a single-stranded RNA virus. It's got really just 4 structural proteins and then 16 non-structural proteins. So very simple virus. Of course, the 4 structural proteins are the spike protein, which we'll focus on in a moment. There's also an envelope, membrane, and nucleocapsid proteins. Now, the spike glycoprotein is really the one that, of course, garners the most attention, appropriately so. This is the protein that binds to the human ACE2 receptors, which are widely present in the human body, but particularly in lung tissue, as well as other parts of the body, such as the heart, kidney, and even the GI tract. One interesting fact around SARS-CoV-2 is it binds with much higher affinity to the ACE2 receptor than the initial SARS virus did from a couple decades ago. And so this is probably one of the main reasons why SARS-CoV-2 has been able to spread so much more efficiently throughout the human population compared to the initial SARS virus. The spike protein itself is depicted here. You can see on the left, it's making contact with the ACE2 receptor on human tissue there in the bottom. There's really just a relatively small area that makes physical contact with the ACE2 receptor. However, as you can see on the right is a diagram of the head of the spike protein. What's pointed out on that picture on the right are a number of key areas of mutations. This is for the alpha virus, but similar graphs could be shown for other variants. And the key point I'd like to make is some of these really important mutations that affect the activity of the virus, some of them do occur in the receptor binding domain. That's the blue area towards the top. However, many occur outside of that area. These are all very closely being monitored now through genomic surveillance to monitor for additional variants that may arise. And we'll talk about a few of these key mutations in just a moment. Now, of course, the spike protein, given its role in binding to human tissue, is really the major source of evolutionary pressure. And I think it's important to point out a key concept in that the evolutionary pressure acting on the virus is going to change over time through the course of a pandemic. Early in the pandemic, when there is very little population immunity to the virus, when the virus is much more novel to the human population, the evolutionary pressure is really to focus on having the virus adapt to the new host, evade the innate immune response, and really just learn how to bind efficiently to human cells. Later in the pandemic, and this is really the phase we're in now, as there is a significant amount of immunity in the population, either through vaccination or through natural infection, the evolutionary pressure is going to shift. And that, I think, is probably largely explains some of the really more recent trends in some of these variants that have evolved more recently over the last several months. So the selective pressure at this phase in the pandemic, when there is more population immunity present, it's going to pressure the virus to become more transmissible and potentially evade the acquired immune response, and specifically antibodies is likely the major area of focus for the vaccine. And this is probably largely why early in the pandemic, variants were not of much concern clinically. However, later in the pandemic, they've certainly become so. This is my attempt to try to simplify a little bit of a timeline of some of the variants that have popped up. So this is, keep in mind, please, a simplistic view of this. So for all the molecular biologists that may be listening, my apologies. But the very first mutation that really gathered a lot of attention and really has now become ubiquitous is the D614G mutation, which was described around April of 2020, very early in the pandemic. This was a mutation that really helped enhance the stability of the virus, helped to increase the efficiency of transmission, also to help increase binding to the ACE2 receptor. So this mutation quickly became commonplace in nearly all SARS-CoV-2 populations. However, it wasn't until much later, really towards the end of 2020, around October, November, December, when these newer variants started popping up. The Alpha variant, as well as the Beta variant, both had the D614G mutation, but also carried additional mutations such as the N501Y and the E484K. And I will just say that those mutations are really located within that receptor binding domain of the spike protein. So they've helped to increase the affinity of how the virus binds to ACE2, specifically the N501Y. But the other effect of these is to potentially reduce the effectiveness of antibody binding. And the E484K in particular was associated with failure of some of our monoclonal antibody treatments because of its effect on that receptor binding domain. Now, the Beta variant, which was initially described in South Africa, in many ways is very similar to the Alpha variant, but it carries an additional K417N mutation. That is relevant because it also reduces the effectiveness of some of these neutralizing antibodies that target the receptor binding domain. And this was what created a lot of concern that this might be an escape mutation. The good news is we have not seen Beta really increase in proportion, and that's largely because of the huge success of the Delta variant, which really emerged towards the end of 2020 as well. You can see it carries some mutations in common with the others. This is D614G and K417. But really notably, the Delta variant has a mutation called P681R. This is really an important mutation for the Delta strain, largely because it's thought through some really well done molecular studies that this mutation helps to enhance the fitness of the virus. So it really helps the virus replicate much more efficiently. And this is probably the main reason that Delta has become so commonplace now. It's not because of immune evasion. The Delta variant is still susceptible to our antibody responses induced from the vaccine. However, the virus does replicate with a much higher fitness. And this is probably why it's become so successful. So this is just to kind of describe the success of the Delta variant. You could see that at least it was described initially in India in the late 2020 time period. It was initially described in the US in March of 2021. And you can see in the graph on the right how quickly Delta, which is represented in that orange bar, went from a relatively small proportion of isolates to virtually 99% of everything that we see now in the United States, Delta. So this is an extremely efficient virus. It's really overtaken all of the other variants. There may be a few reasons for that. You can see the graphs on the bottom there describe some really fascinating work out of China, where they were able to demonstrate that compared to the original strain of the COVID virus back in early 2020, the Delta variant looks to generate much higher viral loads earlier in the course of illness. So what the implication here is that with the Delta variant, people may become infectious sooner with higher viral loads. So essentially, potentially become more infectious earlier on before they really know they're sick. And this is probably why Delta is able to spread so efficiently. A few other key features about the Delta variant. As I had already said, it appears to be more transmissible and has a higher viral load earlier in the course of illness, but also, at least in people that are not vaccinated or have no underlying immunity, it also appears to have longer durations of elevated viral loads. And that's illustrated there with the graph on the top right, with the Delta represented by the red bar. You can see essentially lower cycle threshold values, or another way to say that, higher viral loads for a longer period of time. So this is a virus that's much more transmissible. In addition, as I already said, the P681R appears to improve the fitness of the virus by modifying the way that it is assembled through the trans-Golgi network as it's replicating. So this is probably increasing the fitness of the virus. And there is some clinical data now, although I think it still remains to be seen conclusively. But there is some data to suggest that infections with the Delta variant may be associated with worse clinical outcomes here. And you can see some data, I believe this was out of Singapore, showing a higher odds ratio of oxygen requirements, ICU admissions, or death compared to other variants. So some concern that it may cause more severe illness. I'm going to transition now a little bit away from the virus and talk about the COVID vaccines. And I first want to start with a description of what we know about the safety of the vaccines. This slide here is really just to start off by saying we have given a tremendous amount of vaccines in the United States and globally. Unfortunately, not nearly enough. And there are plenty of places in the world, unfortunately, that have very limited or no access to the vaccines. But at least in the United States, close to 184 million residents are now fully vaccinated. Again, not enough, but it's definitely a good enough number to give us a sense of the safety of the vaccine. I think that's the key point I wanted to say, is that we now have a significant amount of experience to assess the safety of the vaccine. And what have we learned? I think the key message here is this is an extraordinarily safe vaccine. I'm really speaking about all of the US authorized vaccines, so the Pfizer, Janssen, Moderna. This is one of the studies to help illustrate that point. This was recently in the New England Journal. This is specifically looking at the Pfizer vaccine. I like this graphic because it illustrates the potential events of the risk of events per 100,000 in those that received the vaccine in blue, but it compares it to those same risks in those that are infected with SARS-CoV-2 in orange. And I think the key point here is that any of these potential adverse events are generally very infrequent when you look at them in a per capita basis, and pale usually in comparison to some of the events that you may see with SARS-CoV-2 infections. So if we call out a few of these specifically, let's look at, for example, a slightly increased risk perhaps of herpes zoster following the Pfizer vaccination, with about 16 events occurring per every 100,000 people vaccinated. That is something that is not necessarily described with SARS-CoV-2 infection. However, if you look at other things like myocardial infarction, you'll see perhaps one additional case following vaccine per 100,000 people, yet approximately 25 such events following SARS-CoV-2 infection. Similarly, for myocarditis, pericarditis, pulmonary embolism, the risks of these associated with infection really trump any potential risks associated with vaccination. So I think this is a really important graphic that demonstrates the overall safety of the vaccine. I'll call out the lymphadenopathy there, which is particularly high, relatively speaking, in those that have received the vaccine compared to the perhaps infection. But I'll point out that I think this is really a localized immune response to the vaccine that is really transient and doesn't carry any significant adverse health outcomes in the long term. Similarly, in pregnancy, the vaccine was not initially studied in pregnant women. However, there's now been a substantial amount of clinical experience in providing the vaccine to people who are pregnant. This is one study recently published in the New England Journal looking at close to 36,000 pregnant vaccine recipients using the vSafe app to self-describe any potential reactions. And you can see regardless if a Pfizer or Moderna vaccine, very similar rates of reactions across pregnant versus non-pregnant people who received the vaccine. Also, and I think most importantly, when we look at pregnancy outcomes, such as stillbirths or neonatal outcomes, really the important point here is there appears to be no difference in those outcomes in people who received the vaccine while pregnant compared to the published kind of standard background incidence. So this is, I think, very strong evidence in support of the safety of the vaccine. Really, to date, it's remarkable how very few safety signals or warnings have been identified. This is just a summary taken from the FDA material from the Pfizer and Moderna vaccines on the left, where the key concern has been brought up around myocarditis or pericarditis, particularly in the younger population and in males. And for the adenoviral-based vaccine from Janssen, the concern has been around this syndrome called thrombosis with thrombocytopenia, as well as a potential concern for a very small number of Guillain-Barré related cases. So just very briefly around this, and I took this data from the ACIP discussions on these topics. I thought these really were powerful graphics to illustrate the safety of the vaccines. This is data looking at the potential for every 1 million doses of an mRNA vaccine given in the U.S. You could see the potential cases of myocarditis there on the right of that graphic. You can see a very small number of cases of potential myocarditis for every 1 million doses given, which really is paled in comparison to the number of COVID-19 hospitalizations prevented across those same age groups there. So this was really key data that helped to sway the regulators in reviewing this to demonstrate that the risk-benefit profile strongly favors the safety of these vaccines. And even when you look at the highest risk cohort for myocarditis, which would be young males in the age of 12 to 17, you can see that even in that cohort, the vaccine is still, the benefits still greatly outweigh the risks. And the good news here with these cases of myocarditis, which are rare but have been associated with these mRNA vaccines, is that they're largely self-resolving. There have been a few cases of more severe illness requiring hospitalization or ICU admission, but those are very rare and few and far between compared to the potential COVID-19 complications. Now, the story of the TTS syndrome, this is the thrombosis with thrombocytopenia with the Janssen vaccine, is very similar. And this was a similar risk-benefit analysis presented at ACIP back in April. Now, this risk of TTS is really highest in females, typically younger females. And you can see even in that highest risk cohort, of females, for example, age 18 to 49, where for every 1 million people that you vaccinate with the Janssen vaccine, you may expect to see about 7 cases of TTS. However, you would prevent 6 deaths and 56 ICU admissions and 297 hospitalizations in that same group. And it's even more in favor of the vaccine in the older female population, and even more dramatic in the male population. So I think this is all powerful evidence of the benefit of these vaccines when you compare it to the alternative in particular, which is potential COVID infection. Now, we are getting more and more data around the durability of these vaccines, and this is obviously a hot topic. These are 2 recent publications from just the last couple weeks in the New England Journal. The one on the left is for the Pfizer vaccine, the one on the right for the Moderna vaccine. I think the key point here through these data points here through at least 6 to 8 months, it appears these vaccines are incredibly durable in their protection and overall vaccine efficacy in preventing any COVID-19 illness. So I think this is very, very powerful data. You can see perhaps on the right with Pfizer, a little bit of a drop in vaccine efficacy in those that are more than 4 months out from their completing their series. But nonetheless, I think vaccine efficacy this high for both these vaccines is really quite remarkable. And how have these vaccines performed in other trials? There have been quite a few that have been recently published. To just touch on a few, this was one really looking at the clinical effectiveness of COVID the COVID vaccines in ambulatory and inpatient settings. This was looking at adults in particular using a test negative design. This is a nice design because what they do is essentially look at outcomes of everyone that presented for COVID testing and then assess the efficacy of the vaccine in those that tested positive versus those that test negative. The reason a test negative design is helpful is because it helps to remove some of the potential bias for test seeking behavior and such. So with this study design in mind, you can see a fairly large study here. This was across multiple US states. And the key message is that the effectiveness of the mRNA vaccines in general is very high and around 90% against hospitalization, ICU admission, as well as ED or urgent care visits. That's for the Pfizer and the Moderna vaccine. And then similarly, very high efficacy against the Janssen vaccine, 68% against hospitalization, 73% against ED or urgent care visits. So I think for all of these vaccines, I think a very favorable efficacy profile in a more real world setting. This is another study looking at the same question, overall effectiveness of the vaccine on a broad population level. This is looking at 5 VA hospitals in the United States, and the overall vaccine effectiveness of the mRNA vaccines. This is including Janssen and Moderna and Pfizer. The overall efficacy of the vaccine is about 87%. One signal that popped up in this study that is a theme we will see in a few more slides here is that in the age group 65 and older, you can see a little bit of a chink in the armor, so to speak. The efficacy drops a bit. So for those in 1864, efficacy of 95%, whereas in those 65 and older, it's dropped to about 80%. You'll also see that if you go a little bit further down, the Pfizer group with a slightly lower efficacy compared to the Moderna. However, those confidence intervals do overlap. But lastly, you'll see that there's really no difference in terms of those that were vaccinated less than 90 days or more than 90 days. So I think this is overall very encouraging data and the efficacy of the vaccine in another real world population. Also some encouraging data that there are additional benefits to getting vaccinated. I liked this study. This was an evaluation of 92,000 households of healthcare workers. And what they were able to do here was demonstrate that compared to prior to vaccination, after a healthcare worker was vaccinated, their household was less likely to have a positive case. And with a risk there in the household members dropping from 9.4 to 5.9 rate per 100 person years. So I think a substantial drop. And this is really good evidence of the potential for vaccines to help reduce transmission even within household settings. So great to see this data. Of course, nobody cares about that now, and all the interest is on what about Delta? So this is some of the initial data to suggest that the Delta variant, there is still activity against Delta variant, but it may not be quite as robust as what we saw with the initial parenteral strain of the virus. The graph here on the left, first of all, looking at neutralizing antibody titers following the Moderna vaccine. There is, as we would expect, a reduction in the titers of neutralizing antibodies over time. We would see that with any vaccine. I think the good news here is, however, while those titers drop, they still remain even at low levels at 6 months. So that is relatively good news. And you can see the graphs here on the right. This is really looking at the top here on convalescence era, so people previously infected with COVID, and then on the bottom, recipients of the Pfizer vaccine. You'll see that all of the variants may have a somewhat reduced activity of antibodies against some of these variants here. You'll see that Delta is no exception to that. However, I think the key point is that there is still substantial activity overall. And so even though the antibody titers may not be quite as effective with the Delta variant, overall, I think this is somewhat reassuring that there seems to be quite a bit of residual activity across all of these variants. We are beginning to learn more and more now about how our antibody and serologic responds to Delta over time. So this was a very recently released study that is still in preprint. This is looking at antibody responses against the Delta variant specifically after 2 doses of an mRNA vaccine. And there's a lot to unpack here, but I'll just say I think the key point here is that where we seem to see the most concern about reduced effectiveness over time appears to be in our older patient population and those with a lot of substantial comorbidities, specifically long-term care facility residents. So in this data set, the blue circles represent generally young and healthy healthcare workers at the median age of 41. The orange circles represent long-term care facility residents as well as the older patient population. And I think the key point is if you look at the graph there, B on the right, you'll see that when we look at activity of the, or I should say titers of the antibody, over time, you'll see that there is a reduction in healthcare workers 3 months after they've received vaccination. However, that reduction in the older population and the long-term care facility residents is much more substantial. So really what this is telling us is that the most significant declines in antibody activity against the Delta variant appear to be occurring in our older patient population. Now, how is this translated clinically? In keeping in mind that the in vitro antibody titer assays are really just a surrogate. What are we seeing clinically? And this is data from LA County, where we are here at Cedars. And I think this is quite reassuring to see is this was looking at virus activity in May, June, and July. The Delta variant really became the predominant variant in Los Angeles in June and then July. And you can see the case counts in our unvaccinated population, unfortunately, were really shooting up. Same with hospitalizations. The black line represents the hospitalization rate per capita in the unvaccinated group. The good news here is the fully vaccinated group and even the partially vaccinated group, there was a slight increase, however, much reduced in magnitude compared to what we saw in the unvaccinated population. So this is, I think, very convincing clinical data that being fully vaccinated is still highly protective against particularly severe outcomes such as hospitalization, even with a Delta predominant virus in circulation. This is a very similar type of analysis done at a national level, again, during a period of time in the US when the Delta variant was becoming common, really in July. You can see similar trends, case counts going up, hospitalizations going up, deaths going up, but really the bulk of that increase was in the group that was not fully vaccinated. And in fact, the rates of increase in the fully vaccinated group represented by the blue line, we did see an increase in case counts, but the increase in hospitalizations and deaths was very small in comparison to that. So again, very powerful data that these vaccines are still highly effective against the Delta variant, particularly in preventing severe disease. Again, additional data here. This is from the MMWR, looking at 33,000 US adult medical encounters. Again, during a Delta predominant period, this is really July and August. I'm sorry, June through August in the US. So Delta is the predominant virus here. I think the good news here is that the vaccine overall remains very high effectiveness against hospitalization, 86% overall. You'll note that there's a little bit of a reduced effectiveness in the age group 75 and older, where the red arrow is. Effectiveness against hospitalization in the 75 and older group dipped a little bit to 76% compared to the 89% in the younger group. You'll also note a little bit of differences by vaccine type. So you'll see the overall effectiveness against hospitalization from Pfizer is about 80%, Moderna is about 95%, and then the Janssen vaccine is around 60%. So we're starting to see some stratification here by vaccine type in terms of overall effectiveness. And again, similar data here. And this is, again, US data. This is March through August. This data set did not parse out Delta versus non-Delta. Nonetheless, the key point I'd like to make is with the Moderna vaccine, you can see a very high effectiveness over time. When you look at the breakdown of effectiveness prior to or after 120 days after full vaccination, really no difference. However, with Pfizer, you can see that the effectiveness does begin to wane greater than 120 days after the full vaccination, drop down to 77% compared to 91% prior to that. Interestingly, with the Janssen vaccine, really no significant change. in effectiveness over the time period there, although still just limited data with the Janssen vaccine. So again, all of these kind of together suggesting that overall the vaccine effectiveness remains very high, even against the Delta variant. However, we do see some signals of reduced effectiveness in the older population and perhaps with the Pfizer vaccine over a longer period of time. Now, of course, the other aspect of this is our healthcare workers, and this was a very interesting report out of UC San Diego, our neighbors to the south of us. They published this, I think it was very timely. They are a health system of 19,000 employees. From March of 2021, they had a 76% vaccination rate. They've been able to increase that vaccination rate to 87% by July, which is fantastic. However, during the June-July period, we saw the Delta variant come, and you can see that they began to see, as shown on the graph there on the right, an increase in infections with the Delta variant amongst their healthcare workers, both in vaccinated and in unvaccinated workers. So I think this was certainly of some concern. The good news is the vast majority of these were very mild infections, but nonetheless, you can see that their estimated vaccine effectiveness in the month of July dropped from a 95% range to a 65% range. And so this was certainly some cause for alarm. Of that potential waning effectiveness. You can see that their healthcare workers received either Moderna or Pfizer. So these are the results of those two combined. Now, I do want to make an important conceptual point, and pardon me if this is overly simplistic, but I do want to say we will expect to see more breakthrough infections as more people get vaccinated. And the reason for that, quite simply, is math. If you take the example on the left, example one, if you take a hypothetical population of 1,000 people, for example, and you look at a 50% vaccination rate in that population with a vaccine that's about 80% effective, in that scenario, you'll expect to see about 50 cases occur in the non-vaccinated group and about 10 cases in the vaccinated group. So in this setting of 50% vaccination, breakthrough cases, so to speak, appear pretty uncommon compared to cases in unvaccinated people. However, if you look at the example on the right, example 2, same population. However, this is a group that is 90% vaccinated. In this hypothetical situation, same vaccine efficacy of 80%, because the sample sizes are so different, the absolute numbers change. So in this hypothetical, the number of breakthrough cases actually outnumber the number of cases you see in the unvaccinated group. So you may see 18 cases in the vaccinated group compared to 10. So if you, for example, are working in a hospital and looking at COVID cases, numerically, you're going to see more breakthrough cases than you see in unvaccinated cases. And this may give a misperception that the vaccine is not working. But this, I think, is an important concept to keep in mind, because we will see more breakthrough cases as more and more people get vaccinated. And that is not necessarily a sign of vaccine failure. Now, a question has come up around, are antibody titers a good correlate of immunity? And I think it's safe to say that the jury is out, but there is some there is growing evidence, I should say, that antibody titers may be some surrogate of protection. The graphic here on the left was a fascinating study where they identified 39 healthcare workers that had a breakthrough infection and compared them to controls that did not, and were able to retrospectively go back and look at their antibody titers following vaccination. And you can see that in general, the healthcare workers who went on to have a breakthrough case in general had a lower titer of antibodies after vaccination compared to those that didn't. So this is some initial evidence that lower titers may signify a higher risk of potential breakthrough. Similarly, on the right, this is data from the COVE study, which was the study evaluating the Moderna vaccine. You'll see there that in the recipients that had low titers following vaccination, that's the solid green, you can see that over time they had a slightly higher risk of COVID infection over the 100-day period compared to those that had high antibody titers. That's the dotted green line at the bottom. However, I think a very important point here is while the absolute why the relative risk of infection may go up in those that had low antibody titers. Keep in mind the placebo risk is substantially higher. And so the key point here is, yes, it may be true if your titer overall is lower, that your risk of breakthrough may be a little bit higher, but it's still substantially lower than your risk if you're not vaccinated. And I think that's the key thing to keep in mind. What about third doses of vaccines? A lot to say about this. I just selected a couple things to say. This was some of the data that was important in the discussion at ACIP around the importance of booster doses, but you can see that in healthy recipients here, after a third dose of the vaccine, this is with the Pfizer vaccine, in particular for this study, you can see substantially higher neutralizing antibody titers after dose 3. So, a third dose can increase the immune response, so to speak. And on the right, this was a third dose in a highly immunosuppressed solid organ transplant recipient population. Similarly, a third dose in that group can increase the titers. This was part of the data behind the recommendation for a third dose of the mRNA vaccine in heavily immunosuppressed patients. So third doses can potentially boost the response, but what does this mean clinically? Still very limited data on what this means. However, this is really some of the early data we have out of Israel. The country of Israel began boosters for everyone age 60 and above at the end of July. They used the Pfizer vaccine predominantly. This was during a period when the Delta strain was very common. They then went back and looked at 1.1 million people in that population and looked at those that got a booster and those that didn't. And they identified that beginning around day 12 after that booster dose, a substantial risk reduction in COVID breakthrough infections in this group. You can see that the adjusted rate ratio of confirmed infection in the booster group was 11.3 factor less, and the risk of severe illness was a factor of 19.5 less in the booster group. So this is some really encouraging clinical data that booster doses in an older patient population can be clinically effective at reducing breakthrough infections and more severe illness. I will point out this data is very limited. This was a non-randomized population study. There's lots of biases potentially here. Also, this is not looking at the effectiveness in younger patients. This is really 60 and above, so keep all of that in mind. But these were some of the data points brought into the discussion around the role for boosters in the US. I'm running a little low on time, so I'm just gonna go through very quickly some updates on treatment. I will say there's not a lot of things new in the last month or two with regards to treatment, but just to recap a few key points, I will say the NIH keeps very updated evidence-based recommendations for the treatment that you're likely all familiar with. It's available on their website, and I'll just walk through a few of these things. This is my attempt at a graphical representation of really some of the key treatment options we have that the data supports. Of course, COVID-19 exists on a spectrum of illness, anywhere from asymptomatic or mild to more moderate and severe and critical. Really, the inflammatory aspects of the disease really play a much more prominent role in patients with severe and critical illness. And these are the types of patients for which immune modulator therapy, such as dexamethasone and tocilizumab, or some of these JAK inhibitors, where they may play a role. But you can see really the role of monoclonal antibodies, if you have access to them, it really seems to be in the non-hospitalized group with mild to moderate illness, whereas antivirals such as remdesivir really have probably a much narrower scope for which they have really clinical effectiveness. It's really in that patient group that is considered severe, where they may require supplemental oxygen but are not necessarily yet critical. And then you can see the immune modulators, dexamethasone and tocilizumab. I'm going to just quickly walk through a couple key points. One, with regards to monoclonal antibodies, I think the data has been accumulating and is pretty clear that these treatments can be very effective in the right outpatient population, specifically people that have mild, moderate illness and are at high risk of clinical progression, specifically people with older age or obesity or diabetes or cardiovascular or lung disease risk factors. In these groups, it appears that monoclonal antibodies can do a really good job at protecting people from hospitalization and from death. That's really the data here with the Regeneron product shown below, where you can see the very, very powerful difference between those patient populations in those who got it compared to placebo. These are relatively safe treatments. Hypersensitivity reactions are the major adverse event. And I will point out the major logistic and resource limitations go along with that go along with administering these treatments. These are very resource intensive to administer. Not every place can administer them, so this is really the main limiting factor in these treatments. Very quickly, corticosteroids. I think that the data has been really clear. This is data from the recovery trial in the UK, where you could see the clear benefit of dexamethasone in reducing mortality, specifically in the patients with more severe illness. You could see in patients with severe or critical illness, the benefit was really dramatic. However, in the group that was milder illness that did not require oxygen, for example, there was really no benefit and almost actually a flipping of the curves, and there was a potential of harm in the group where there was really no underlying need for oxygen. So in patients with mild disease, corticosteroids are really not indicated and potentially could cause harm. So I think that's an important point. I will say that there have been a number of studies that have shown the same thing. So this data has been corroborated by multiple other studies. This is likely a class effect. So corticosteroids in general, for the right patients, really more with the severe illness requiring oxygen, very clear mortality benefit across a variety of different types of steroids and different doses. So I think, very clear data here in terms of mortality benefit. Remdesivir is at the moment the only FDA-approved antiviral treatment. The FDA approval really came with the Act 1 trial results here. And again, this trial was stopped early because it reached its primary endpoint faster than anticipated. The endpoint was recovery time, 31% faster recovery time overall with remdesivir. There was no mortality benefit, although there were favorable trends. However, in the sub-analysis of patients that required supplemental oxygen, there actually was a significant mortality benefit with a hazard ratio of 0.3. So there was some suggestion really that with remdesivir in the right population, it can be a very helpful treatment, but really not necessarily for everybody, really dependent on the phase of illness. And actually in the patients that were the most severely ill, those that were already intubated, the clinical benefit was really marginal to really not detectable. The Solidarity trial by the WHO also cast some doubt on the potential role of remdesivir. In their study, which was a very large global study that looked at 2,700 patients, you could see where remdesivir was not associated with mortality, which was their primary outcome. There were a lot of limitations to this study that I don't have the time to get into, but suffice to say, the bulk of the mortality here was driven by the patients with more severe illness, those that were already on a ventilator. And this was the group that the ACT trial suggested there was probably no benefit to begin with anyway. So again, remdesivir, the bulk of the benefit may be in those that are sick enough to require supplemental oxygen, but not yet sick enough to require invasive ventilation. And then just very lastly, I'll say there's been a lot of interest in these other immune modulators, IL-6 inhibitors and JAK inhibitors, and they are recommended in very specific circumstances. For example, patients that are kind of abruptly decompensating with a severe systemic inflammatory reaction. This is the patient population for which there have been several trials. I picked one here to demonstrate on the right, where there may be a mortality benefit in giving some of these other immune modulators in that right patient population. So I think selectively used, these treatments can be beneficial, even with dexamethasone. But again, it's really about selecting the right patient to use these in. So that's really the bulk I wanted to say. Sorry, I went a little longer than I had planned. Just to briefly summarize, the Delta variant has become the predominant variant, likely because of mutations that have facilitated its transmissibility and its fitness. It's not because of immune evasion, although it's still not clear. It does appear it may be associated with worse clinical outcomes compared to the other strains. With regards to the US authorized vaccines, I think it's safe to say they have a very strong safety record to date. They are highly effective, particularly against severe illness and hospitalization, even with the Delta variant. Booster doses, so to speak, may have benefits in selected populations, such as the older or more immunocompromised. And lastly, the effective therapeutics really vary depending on the clinical status of the patient. Monoclonals can be effective in the outpatients with milder illness, and then corticosteroids, remdesivir, and potentially these IL-6 or JAK inhibitors can improve outcomes in selected hospitalized inpatients. So with that, I'd really like to thank you for your attention. Happy to try to take any questions you might have.
Thank you. There are questions in the chat, Dr. Grein, if you can take a look.
Yes, okay. So looking at the chat here, is there a difference in the clinical course for hospitalized breakthrough infections compared with the unvaccinated? That is an excellent question. And I will be fair to say, I don't think there's really any good data to answer that question. So I'm not aware of any data to suggest a different clinical course in a breakthrough compared to unvaccinated. I think we can safely say the risk of severe illness in general is much less for people that have been previously vaccinated. However, in the subset of people that have more severe illness, I'm not aware of any differences in clinical outcomes. So it's a great question. Next question I see here, do you think third doses will be recommended for Moderna and J&J recipients? Yeah, great question as well. I don't pretend to be able to predict the future. I have not yet seen all the data. Not all of the data has been made available. I will say that the J&J data preliminarily, I've seen some initial data that a second dose of the J&J vaccine seems to really boost effectiveness overall. I, in my personal opinion, think a booster for the J&J will likely be approved in the near future, but I don't have any inside information on that, just based on the data I have seen. Moderna is an interesting story because the effectiveness, there has not really been any data to demonstrate waning of immunity or effectiveness with Moderna like we did see with Pfizer. And this may partially be because the Moderna dose used is higher than what Pfizer used. And so I don't know if Moderna, if there will be recommendations for a Moderna booster, because we haven't seen any evidence of waning yet. So I think more to come on Moderna. It'll be fascinating to see what data comes out. Another question here. Are monoclonal antibodies effective for mild to moderate infections from all current variants? Great question, and I kind of I glossed over that, so my apologies. So the monoclonal antibodies, one of the key weaknesses of the monoclonal antibodies is they can be very susceptible to different variants, meaning based on the mutations in the variants, some of the monoclonal antibodies may not work. And we saw that very much with the epsilon variant, with some of these E484K mutations that were particularly prevalent in the US earlier. And at that point, actually, some of the monoclonal antibodies were no longer recommended because those variants were common and the monoclonal antibodies were not effective against them. However, with Delta, all of the current monoclonal antibodies appear to remain effective against the Delta variant. So probably the only good thing that came out of the Delta variant surge in replacing all the other variants was that it allowed all of our monoclonal antibodies to remain effective against it. But I think, future variants, we will have to see how they impact monoclonal antibodies. Looking at the next question here. Are there any studies looking at the potential of development of autoimmune diseases following the mRNA vaccines? Yeah, it's a great question. I have not yet seen any data to suggest development of autoimmune diseases following mRNA vaccines. I do know anecdotally people have talked about people with pre-existing autoimmune diseases perhaps having some sort of flare of their symptoms following an mRNA vaccine. However, I have not seen any data to support the development of a new autoimmune disease. Obviously, that will continue to be monitored, and we will see. I don't think there's any reason to think that we would expect that, but probably more to come. Let's see. Looking at the next, I'm just kind of going down the list here. We're able to see Guam's COVID-related hospitalizations for vaccinated and unvaccinated. It seems like Guam's numbers are different from global numbers because of breakthrough hospitalization rates are higher. So that creating questions about Guam's vaccinations. Yeah, it's a good question. I have looked briefly at some of the data from Guam. I do not profess to be an expert in the epidemiologic aspects of what's happening in Guam. So many of you may be more facile with this data than I. I don't know how to answer that question. It's a great question, and I don't know if there's a. I can't really give you a good answer. I think I know there's certainly concern about perhaps a higher proportion of breakthrough infections in the patient populations you're seeing. I don't know if we have any time. I'd love to hear from any of you about any of your experiences. I don't really have any data that I could share that I answer that. I wish I could. My apologies. And yeah, I am happy to provide these slides for the group if that would be of any help. See a couple other questions. Will the Moderna vaccine be approved for children? I don't know the answer to that. However, I know that they are currently being evaluated. I think there will be a lot of data coming out with regards to Pfizer and Moderna and other vaccines in the children age cohort. So much more to come on that. I do not anticipate seeing any major safety signals in the younger patient population based on some of the preliminary data we've seen with these mRNA vaccines. But I haven't seen all of the data set yet. It has not yet been made available, so have to follow that. Question here, are people with underlying medical conditions more likely to get infected and become breakthrough after vaccination? The data we have is that it appears the highest risk of breakthroughs is in those that are older, and potentially in those that have underlying comorbidities, but that data is less clear. Really where the bulk of the data is in immunosuppressed and in older. So I think really the highest risk for a breakthrough would be in those that have underlying immunosuppression, those that are 60, 65 and older. With regards to people that are younger but with underlying comorbidities, to be perfectly honest, there's very limited data. And we just don't know yet what their true risk of breakthrough infections are in that patient population. Some great questions. I probably am getting close to time, so I'm sorry. How do we overcome the mismanagement or the misinformation, I should say, against the vaccination now that a booster is recommended? Boy, I wish I knew the answer to that. Yeah, I think it's obviously the misinformation challenges have been significant. I think I think in my mind, just trying to be as transparent and forthcoming as we all can as healthcare providers and trying to have those one-on-one dialogues with people that may be hesitant is really the only way we can move forward. Unfortunately, people have very different reasons for being hesitant for the vaccines. There's not one reason that everybody gives. And what that really means is we have to really listen to what each individual person's concerns are about why they may be hesitant to get the vaccine and do our best to try to counter that with the data we have. And that takes a long time, and it requires establishing trust with the community and with our patients. Maybe I'll pause. I don't know if our moderators would like to say anything. I feel like I've been talking a long time. I really appreciate everyone's attention.
Thank you. It's awesome. Yeah. How about Dr. Desai? Do you have anything to say?
No, I think that was fantastic, Dr. Grein. There's a lot of questions still in the chat. Quite a few people are asking for your slides and even a follow-up session. So we'll make sure that the information gets to the group. But I want to thank you. Thank you so much for your expertise. It's fantastic.
Wonderful, wonderful presentation.
I really appreciate it. Hope this was helpful. Happy to make the slides available and just let me know. I'm sorry that it couldn't be in person. I'd love to be able to hear everyone's questions in person, but thank you for having me.
Thank you. We are approaching the end of this 1-hour session. Thank you, Dr. Grein, for the great presentation and learning experience. Thank you, everyone, for a great discussion. Again, please claim your CMA credit within 14 days. Our next session will be in November with a focus on women's cancer. Looking forward to seeing you again next time. Please enjoy the rest of your day. Thank you, everybody.
Thank you.
you.